Good evening, everybody, and welcome to our webinar this evening on vaccines and cystic fibrosis. I hope you're getting the same lovely sunshine as we're getting here in Skerries, where I'm speaking from. And my name is Philip Watts, and I'm CEO of Cystic Fibrosis Ireland. I think everybody knows this is both a hopeful time and an anxious time for everyone with CF and their families as people receive or wait for their vaccines. Many people with CF have been sheltering in their homes over the last 12 months, and the vaccines now offer a road to normality, though we have to remain cautious and careful. The vaccination programme for adult patients appears to be going well, and of course we look forward to the time when vaccines will also be extended to young people and children. You may also have heard on the news today that there have been some changes to the vaccination programme, which we may hear more about in this evening's webinar. So we're delighted to welcome two very distinguished speakers to help provide information and to answer our questions. And those are Professor Martin Cormican and Professor Gerry McElvaney. You've very kindly sent us in a list of questions, which I will put to both Gerry and Martin following their presentations. And we'll finish the webinar with a panel discussion, which includes my colleague, Dr. Sarah Tecklenborg, our Chairperson, Keith McCabe, and our Vice Chairperson, Patricia Duffy. And so without further ado, I'm delighted to welcome Professor Martin Cormican, who's HSE Clinical Lead for Antimicrobial Resistance and Infection Control. And you may well remember, Martin, you took part in our previous webinar on returning to school. So over to you, Martin. I know he's going to share some slides with you as well.
Thank you. I'm going to try to share some slides. It's always an adventure to see if it works. So thank you very much, and thanks for the opportunity to meet with you again. I suppose the first thing I would do is echo what you've just said there, Philip, is don't drop your guard. As you said, the vaccine is tremendous, but there has been experience in a number of countries of people who get the vaccine and think that they've got instant protection, and there's been a phenomenon in a number of countries of people catching COVID soon after the vaccine because they thought they were okay before they were. So we're going to talk a little bit about that. So let me see if I can make this move. Okay, so the benefits of vaccine, and just to say that there's two elements, the benefits for the individual and the wider benefits. All of the vaccines have shown really dramatic effects in reducing illness severity and reducing death. And they reduce the incidence of infection also. And they increasing evidence as well that if you do get infected after you've had the virus, it looks increasingly good evidence that you make less of the virus than if you were not vaccinated. And that is expected to reduce the risk that you spread it to others. It's important, I suppose, in terms of where we are with the vaccination program at the moment, that what we're seeing is primarily the benefits for the individual. So if a person has completed their vaccinated program, then it gives very good protection to them. In terms of the protection for the wider society, where we get to the stage where enough people are vaccinated to slow the spread of the virus, we are quite a long way away from there yet. Some countries are getting close now because they've got a very high proportion of people vaccinated, but we are a long way from that yet. But we are seeing impact on hospitalization. We're seeing a huge impact on frontline healthcare workers. It's really dramatic. In our worst week in January, and January, as all of you will know, certainly any of you who were in hospital, was a really difficult month. In our worst week in January, we had over 1,000 healthcare workers who got infection in a week. And in the last couple of weeks, we've been looking at numbers as low as 14. Now, there's a number of things in that, but a lot of that is down to vaccination. So we are seeing real benefits happening. So, and then if I move on, this is just a summary of how we're doing in the vaccination program. Lots of numbers, but what shows is that briefly the long-term residential care facilities mostly done, but again, there are always new people and people you have to go back, people maybe who didn't want the vaccine and do want it now. So, but substantially done. Frontline healthcare workers substantially complete. A lot of progress on the people of 70 years and older, and of course, there's been progress on the allocation group 4, which is people with medical conditions that place them at very high risk. We were moving forward with that as quickly as possible, and we'll come back on that. And that's probably the one of most immediate concern to most of you. And then there's also another allocation group, 7, for people with high risk. So there's very high risk and high risk, and there are different allocation groups. And I'll come back to talk about that. But so there is progress. I'm just going to talk a little bit about the background to the vaccines. Now, for those of you who have who have a lot of knowledge of the science, some of this is going to be a bit basic. So many of you already probably have very widely on this. So when I talk about vaccines and how they work, the general principle of it and is, to me, I think of it as being like training for a race. And this is because I like to run. So when the virus infection occurs, it's the start of the race, and the virus starts to multiply, and the immune system starts to get into shape to deal with the virus. And the race is about how fast the virus can multiply and how fast the immune system can get ready to outrun it. So a natural infection, you have a good outcome if the immune system wins the race. So the immune system starts dealing with the virus before too much damage is done. And a poor outcome is if the immune system loses the race. And essentially what the whole principle of vaccination is to get the immune system into training before the virus gets to the start line, so that the immune system has already done its training and it's ready to go, and you don't lose that 10 days to 2 weeks while the immune system is getting itself up to speed. So the available vaccines that we have at the moment are Pfizer, Moderna, and AstraZeneca. And Johnson & Johnson has been approved by EMA, but it's not yet available for use in Ireland. And right now, there is no vaccine licensed for use in those under 16 years. It's not, I think it's important to say, I don't think anybody expects that these vaccines are not going to work, or I don't think anybody expects that these vaccines are going to be unsafe in people who are under 16. It's just that studies haven't been published yet. I understand that some of the companies are doing studies on people under 16, and my expectation is that these will work fine and that they will be safe in people under 16, but the studies haven't come, so they're not licensed for use in that group yet. And so we're going to have to wait a bit for that. We're going to have to wait a bit in any case, I suppose, because the vaccine supplies are such, although it does look hopeful that that's going to improve over the next couple of months. So in Ireland, the Department of Health has directed that those who are aged 70 years and older must receive mRNA vaccines. So if you're 70 years or older, then the only vaccine that's being given to that group in Ireland at the moment is one or other of the mRNA vaccines. How do the vaccines work? Well, all of the available vaccines carry a genetic code or genetic recipe into the cell that tells the cell how to make a fragment of the virus. So important to say that they do not code for the full virus. They just code for a particular part of the virus, a protein that's very important in the virus's ability to attach to a cell. And for the virus to get into the cell and multiply, it first has to stick onto the cell. So this is the spike protein. And so this is important because the vaccine can't cause infection because it doesn't include the whole virus. It includes just, as I said, just this piece, a message to the cell to make this piece of the virus. So that virus protein is a protein that is key to the ability of the virus to cause infection. And it's also a key part of the immune response to the virus. So your immune system can practice on that protein essentially. And then when the virus turns up, your immune system, as I say, it's already at the start line, it's already done its training, and you don't have to lose that period of time while it gets into shape to deal with the virus. The vaccines differ a bit in how they work. The mRNA vaccines, which are Pfizer and Moderna, as the name applies, it's messenger RNA. So it takes a message about how to make the virus protein, and it takes it directly to the system and the cells that make protein. So for people who are interested in biology or have studied biology, you will remember that there's a system that the ribosomes which make protein. So in the normal way of things in our cells, if we need to make a protein, the core message on our DNA gets translated into, it gets transcribed into messenger RNA. And then that piece of RNA goes to the protein factory and tells the protein factory to make the protein. In the case of these vaccines, what we're doing is we're sending the message directly to the protein factory. And that's what the mRNA vaccines do. A message directly to the protein factory that says, here's how you make a piece of the virus. And then the immune system looks at that piece of the virus and practices on it. The other two viruses, AstraZeneca and Johnson & Johnson, are a bit different because here the message is carried in an adenovirus, a different type of virus. This is a virus that is been modified so that it doesn't multiply in people. It's also been modified so that a part of its genome has been replaced by a piece of DNA that codes for a piece of the SARS-CoV-2 viruses that causes COVID. So this adenovirus is able to get into the cell, and it carries with it that message. And that message goes into the cell nucleus. The cell nucleus then makes a messenger RNA, and that messenger RNA goes to the cell factory. So in a sense, all four of them end up in the same place, the message to the cell protein factory to make a piece of virus, but they get there in a slightly different way. The messenger RNA goes directly to the protein factory, and the other ones carry a message to the cell nucleus where the messenger RNA is made, and that goes. So that's the somewhat difference in how they work. All of the vaccines appear to be highly effective in reducing the risk of severe disease and death, and the evidence for that is gotten better as the months have gone by. Many of you will be aware that in the early studies, the reported efficacy in preventing infection was 94 to 95% for the mRNA vaccines. And in the early studies, they reported 60% for the AstraZeneca. But the more recent studies for AstraZeneca have been much more positive and have reported protection as high as 82%. And as I say, when you look at the protection against disease and death, then it's extremely high for all of the vaccines. The mRNA vaccines are given at 2 doses at 4-week interval, and the AstraZeneca vaccine is given 2 doses at 12-week interval. Why the difference? Well, the evidence is that the AstraZeneca vaccine gives a better response overall with the longer interval. So this has changed a bit through the period that we've been working with this vaccine, because at one stage it was 4 to 12 weeks, but most countries now have moved essentially to the 12-week interval because it looks like that works better. Adverse effects and possible adverse effects. So common adverse effects of vaccines, and some of you have had the vaccine and you know that it's many vaccines, bitter pain and discomfort at the injection site is very common. People feel tired, headache, muscle and joint pain, chills and fever. From people I know who've had the AstraZeneca vaccine, and they tell me that quite a lot of people feel really a bit knocked out the day afterwards. Most of the people I've talked to were fine after a day, but actually quite a lot of people really feel a bit knocked out for at least 24 hours afterwards. So I think you can expect that it does. The positive side of that, I suppose, as one of my colleagues said to me after the AstraZeneca vaccine, is that they felt knocked out for a day after it. But in a way, they actually also thought, well, that means my immune system has noticed it and my immune system is working on it. So she was actually quite encouraged in a way by the fact that she was reacting to it, which of course is what you need to do. And then there are some rare general adverse effects, of which the most one that people will have heard about and there are concerns about is severe allergic reactions, specifically anaphylaxis. So every place that's giving the vaccine has to have a plan in place to deal with anaphylaxis if it happens, because it can happen. It's a lot of people worry about, if I ever had anaphylactic reaction to anything, can I have the vaccine? And the answer is yes. The contraindication is if you have had anaphylaxis to the vaccine or to any of the vaccine components. So, for example, another colleague of mine at work who was very concerned about shellfish allergy, the answer was yes, that's okay for you to have the vaccine. They may observe you for a longer period after you've had the vaccine, but there's no shellfish components in the vaccine. So the fact that you've had an anaphylactic reaction to shellfish doesn't mean you can't have the vaccine. Another one I've heard from a lot of people is worries about penicillin. Again, there is no penicillin in the vaccine. So the fact that a person has had an allergic reaction to penicillin doesn't make you any more likely or significantly more likely to have an anaphylactic reaction to this. People, if you've had a history of anaphylaxis, most people will be observed for a bit longer before you leave the vaccination center, but it doesn't mean you can't have the vaccine. But if you've had anaphylaxis to the vaccine or to one of the components of the vaccine, so real medical contraindications to the vaccines are actually very uncommon, but there's a lot of worry for people who have had various problems over the years and feel concerned and fearful, which is understandable. Then in relation to individual vaccines, again, the things that most of you will have heard about that have caused particular concern were the reported deaths in Norway and other countries with the mRNA vaccine. These were particularly in people in very advanced years who received the vaccine. And in many cases, there were people who were probably had a very short life expectancy. It wasn't at all clear, and it hasn't become clear, that that was related to the vaccine. One of the things I suppose we would be saying here to people is that if people are very close, if you're looking at a person who is very, very advanced illness and is very close to the end of their life, it's not really fair to give them the vaccine, because they can't expect to get any benefit from it if they're not. So we haven't had a major problem with that here, although of course there will be older people who have died after they got the vaccine because they were very unwell before they got it. So that signal hasn't panned out. I mean, still nobody is dismissing it and everybody is very careful, but that doesn't appear to be a major issue. And then the second big one that most people are aware of is the reported issue of clotting and bleeding disorders and low platelet count with the AstraZeneca vaccine. So this has been associated mainly with people under 55, mainly women, and within 14 days of the vaccine. The EMA have looked at the evidence for this, and the association is clear. So association, is it associated? Does the vaccine cause it? I don't think we have a definite answer to that yet, but I think that there is the association. My sense is that in the longer term, we'll be moving towards a conclusion. I think that there is a causative link, but it's very rare. Now, that's not a decided opinion because I'm not the European Medicines Association and I haven't seen all of the evidence. But my sense is that this is something that does appear to be a concern, but is very rare. And it may occur there are risk factors that appear to be associated with it in those who suffer it. So what to be aware of after the AstraZeneca vaccine is a new onset of breathlessness, a new pain in the chest or stomach, swelling or coldness in a leg, severe or worsening headache or blurred vision after vaccination, persistent bleeding or multiple small bruises. And we're saying to people, if you experience any of these in the 2 weeks after the vaccine, then you need to contact your doctor. In many cases, it will turn out not to be anything very serious but it's better to be on the safe side. So the message is, if you have any of these symptoms in the couple of weeks after the AstraZeneca vaccine, it's best to contact your doctor. They'll talk to you. They'll work out whether you need any tests to assess to assess whether you're maybe suffering from a side effect. So one of the questions we get asked a lot is, how is the sequence of vaccination decided? And so I'll just outline that briefly, is that the National Immunisation Advisory Committee make a recommendation to the Department of Health. The Department of Health and the government then direct the HSE on who gets vaccinated in what order. And then the HSE's job is to implement the vaccination program based on the government policy and sequencing, and taking into account practical considerations, because sometimes the operational, putting it into practice, it takes a degree of interpretation. So broadly speaking, what we try to do in the HSE is to implement the program as near as we can, practically speaking, to the direction that of government policy based on the NIAC guidance. I'm not going to try to talk you through all of this slide, and some of you will know that there have been media reports this evening that some of this is going to change in any case, but this is what was published on the 26th of February, and you can see lots of different categories in terms of the sequencing here. And the main ones of interest, I think, to you probably will be allocation group 4, which is people at very high risk of severe COVID, and allocation group 7, which is people at high risk of severe COVID. So, people with cystic fibrosis may be in one or other of those groups, depending on the severity of their disease. And I thank the clinical program for cystic fibrosis for all the work that they have done on giving as clear as possible definition as to severe, what means severe and what does it mean to be stable in this context. So again, I'm not going to attempt to read through the slide, but it's just to show you, I suppose, briefly, just how the challenge for us now. I was saying at the start to Philip, this is a challenge that the HSE were delighted to have. I think we were really pleased to see allocation group 4 being recommended by NIAC with the change in February, and the vaccination of people at very high risk and high risk. But it has been a really challenging job to do because it's very complex. It's not just about the diagnosis the person has. And as you can see here, there are 13 different main categories here. And many of the main categories, if you look at immunocompromise, is divided into multiple subcategories. And in addition to the different diagnosis, we have to look at how severe the illness is. So this has been a really challenging thing to find people, to look at how severe their illness is. And of course, we don't have in Ireland a diagnostic registry. So we've been working very hard on it. And for those of you who haven't been vaccinated yet and who are frustrated, I'm sorry for that. We really are trying as hard as we can to get to people as quickly as we can, but it has been quite a challenge, I have to say. And then there's been the limited supply of the vaccine, which makes everything more difficult, of course. So where you see the blue there, those were groups that NIAC said it would be preferable to give them the mRNA vaccine if possible. And that doesn't apply to people with chronic respiratory disease. So it doesn't really apply in terms of cystic fibrosis. But even where they said it applied, what they were saying was that it was preferred if it didn't cause a delay in vaccination, because NIAC are very clear, as the HSE and I believe everyone, that the vaccine that you get the soonest is the vaccine that we want people to get, particularly people at very high risk. So where are we? Allocation group 1 is substantially complete, 2 is substantially complete, 3 is ongoing in general practice using the mRNA vaccine. Group 4 is ongoing through the acute hospital system. It's made some progress, more progress this week, and we hope that will speed up as the weeks go on. Allocation 5, 6, and 7, the planning for that is well advanced, but I can't, I'm not in a position to tell you exactly how that's going to work at the moment, because there's still some negotiation with some of the people involved, but it's hopeful that we will be making progress with that soon. Again, everything depends, of course, on the vaccine continuing to come through. So lots of vaccine has been administered all over the world. Some countries are very far advanced. Within the European Union generally, we have a relatively low proportion of people vaccinated, but the vaccine has been directed mainly to the people who have been most exposed or who suffered the most severe disease. We've talked about the different vaccines that are available. So I just say thank you. I suppose my summary is that vaccines are medicines. And of course, people with cystic fibrosis generally take a lot of medicines. And medicines all have some risks of adverse effects. And so they must be used with care. So as I say, I often say to people, there's a reason why you need a prescription for a medicine. It's because it's a biological agent, and most medicines have risks of benefits and risks of harms. And that's true of vaccines as well, even though vaccines are generally very, very safe medicines. If you compare the adverse effect of most vaccines, for example, to ibuprofen, which people buy over the counter, or to many other medicines that people take, actually they have a really good safety profile, but they're not perfect, and there is a risk of adverse effects. And the overwhelming opinion is that the seriousness of COVID and the balance of risk is very strongly in favor of vaccination. And that's the opinion of really everybody I know who's looked into this seriously. So is there a risk of adverse effects with the vaccines? Yes, there's a risk of local adverse effects and feeling unwell the day afterwards. The risk of anaphylaxis there with all the vaccines, although very rare. And there is this association with the adverse effect with the AstraZeneca vaccine, which again is rare. But if you look at it all on balance, as I say, I think given the risks of COVID, it's very clear to me that the vaccine that you can get the soonest is the vaccine to take. So I'll stop there and I'll try to answer any questions. But you won't find it hard to catch me out if you ask me memory questions, I can tell you. But if there's something I can't answer, I'll make a note of it and then I'll try to get back to you with the answer subsequently.
That's brilliant. Thank you so much, Martin. And maybe we might just save the questions after Gerry's presentation, or to just talk to us. And many people will know Professor Gerry McElvaney is a consultant respiratory physician in Beaumont Hospital, and he's also Professor of Medicine in the RCSI. And he's been a really good friend to Cystic Fibrosis Ireland for so many years. So Gerry, you're very welcome, and just to get your informal thoughts on how the process is going and the vaccines themselves.
Thanks very much, Philip, and I'd like to thank the CF Association for giving me an opportunity to talk to the patients and all our people with CF throughout Ireland. And I'd like to thank Martin for a really excellent talk. So when the COVID pandemic hit us, and seems like only yesterday, but it's over a year ago now, we in the CF world were very worried. We were very worried that our patient population, particularly our people who are in hospital a lot, would be very much exposed and would get very bad results if they got COVID infections. And it didn't pan out like that. And that's a really reassuring thing. And that's one of the things I'd say to all the people with CF, that it didn't pan out that all our people with CF who got an infection got a very severe infection. And even the ones who got very severe infections, they actually managed to pull through in most cases. So in many cases. So this is very, very reassuring. And that's a very important point to make. And I think it's partly because of the tremendous habits that our people have built up over the years. So if you talk to a person with CF, they're used to keeping away from other people who may have infections. They're used to wearing masks. They're used to keeping away, isolating themselves in certain circumstances. And that really stood them in good stead. And we've seen this in a lot of our people who have chronic lung diseases other than CF as well. So I look after a lot of people with emphysema, for example, and they weren't getting as many infections as they normally get during the year because they were cocooning, keeping away from other people, wearing masks, practicing good hand hygiene, et cetera, et cetera. And our people with CF did even better than that. So in our experience in Beaumont Hospital, we had a really tough time in the first wave of the pandemic. And as Martin said, a tough time again in January of this year. But in the first wave, we had a number of our people with CF who got COVID infections. And a number of them sailed through it, no problem whatsoever. Whereas in the one person who got a very severe infection, that individual unfortunately got very sick, but again, came through it quite well. So the point being, and this is a very important point to register, I think, with people with CF, this is not a death sentence. If you get a COVID infection, it is not at the end of the line in any way, shape or form, because we know how to deal with this infection now. We're much better at dealing with it than we were in the past. And the big advantage a lot of our CF people have, which other people don't have, is they're young. Most of them are not overweight. They have a problem with their lungs, but the rest of their body is usually quite good, quite fit and healthy. And that has been the lesson for us in this. So the bottom line is that people with CF can get severe COVID infection, but they can certainly pull through it. And a lot of our people with CF who get COVID infections don't get very severe infections. So I'll leave it at that. I'm more than happy to answer any questions that people might have.
Thanks very much, Gerry. That's very much appreciated. And I'd just like to put a number of questions that have been sent in to us. And please feel free to use the chat function as well, because we will be taking some questions that people want to put during the webinar. But one of the questions that came out very strongly was, have people with cystic fibrosis been tested with the vaccines, or that any of the vaccines, you know, during the clinical trials for the vaccines? Did people with cystic fibrosis, were they included in those trials?
I have to say, if that's a question for me, Philip, you've caught me. You've proved with the first question that it's easy to catch me out with questions of memory. I honestly can't remember, and I won't guess. I would have to go back and look at that. I don't recall, in terms of the exclusion criteria, I don't recall that they were excluded. But if there were cystic fibrosis patients in those trials, my expectation is that there were probably very few. But I couldn't, and there are no trials that specifically addressed cystic fibrosis, to my knowledge. But I don't think there's any reason to expect that the vaccine would work differently in people with cystic fibrosis than it works in the general population. And certainly the trials did include people with medical conditions that placed them at significant risk. But as I said, as to whether there were any CF patients, I honestly don't know. I think if there were probably relatively small numbers.
And again, probably to you, Martin, is how long will a vaccine provide protection against COVID-19, or do we know?
I'm on a roll here of questions that I can't answer. Nobody knows is the answer, really, because obviously we've only started using them since December. What we do know, and is maybe relevant, is that immunity as a result of natural infection is good for about 6 months at least. It may be good for longer, but again, with that, we're still in the early days. But HIQA, the Health Information and Quality Authority, did a very comprehensive review of the evidence in the last maybe month or 6 weeks. And they're said the evidence is very good that if you have COVID and if you that you are very unlikely to get COVID again in the 6 months after. And that may be longer, but we just have to wait for the evidence to build up. I suppose it's very important to emphasize that it's very unlikely, not impossible. People do get COVID again. And so we have seen people get COVID more than once. And there is a concern, and this is one of the concerns about these variants that people have heard talk about, is one of the concerns is that we might see variants that the vaccine doesn't work so well against. And people will be familiar with that, I'm guessing, from the annual flu vaccine. So if you had flu vaccine last September, October time, the flu vaccine that you had was actually slightly different from the vaccine that you had if you had it 5 years ago, because the flu vaccine changes over time as well. So we have a lot to learn about this virus yet. All viruses change. This one is changing too. And what I'm pretty confident about is that if the virus does change so that the vaccine that we have now doesn't work, that it should be technically fairly straightforward to change the messenger RNA, to change the message in the vaccine should be possible to make the vaccine work against variants if they emerge. But there is a big concern, and that's why the quarantine hotels and so on have been introduced. The main thing there is we're not that worried about somebody coming in with the virus if it's the same virus, if it's the same variant we already have. The main worry is that somebody might come in and bring in a variant that the vaccine doesn't work so well for.
And Martin, are the existing vaccines good against the variants that we do know about?
The existing vaccines we're pretty confident are good against most of the variants that are available in Ireland. There is a concern about the vaccine that was first recognized in South Africa, that may be less, some of the vaccines may be less effective against that. But again, less effective doesn't mean not effective. And against the main virus in Ireland at the moment is the one that in December we were calling it the UK variant, but it's now also the one that's the vast majority of the virus circulating in this country is now what we were calling the UK variant in December. And the vaccine, the evidence is that the vaccine works well against that. As I said, we do have some cases with what was called the South African variant in the country. small numbers, and there is less confidence as to how good all of the vaccines are against that. But as I say, at the moment, that's small numbers of virus.
And Gerry, one for you. How is the vaccination program rolling out? It's maybe just describe it. It's been done in CF centres for people, and
it's working quite well actually. So as you know, Philip, we're looking at people who are in the sicker end of the spectrum, people whose lung function is less than 40%, or people with low BMIs less than 16. And then there's some other things as well. Like if a person's getting a lot of exacerbations, we'll get them vaccinated early. If they find the person needs a lot of intravenous antibiotics over a 12-month period, we get them in as well. And then there's some other groups, for example, who may have bacteria which we know are associated with sort of unpredictability in CF, such as Burkholderia or atypical mycobacterium infections and that sort of thing. So it's rolling out very well, I think. And I think I'd like to pay a particular tribute to Charlie Gallagher in this. He's done a really good job in rolling out and getting all the CF centres singing off the same hymn sheet. And our hospital has been very good. We've given a lot of people done. And I think the people with CF appreciate that. But I think, as Martin has said, we'll only be happy when we've everyone vaccinated.
Yeah, and we'd like to add our thanks to the National Clinical Programme and Professor Gallagher as well for all his work. And just in terms of the pre and post-transplant patients, we know the Matter, we're calling people in early this week, which is really, really positive. Is there any issues around, will they have the same vaccine as those who are not pre and post-transplant?
They will, as far as I know. Martin might want to speak on that. I think they will, yeah. And the data from the Matter has been very good. There's a bit of a concern earlier in the week, as you know, but they really rallied the troops, and a lot of their patients have been taken in and getting their vaccines now in the Matter Hospital.
Yeah, that's right, Gerry. It will be the same vaccine. The people who have had transplants, they would be, if you remember, I talked about the blue boxes in so people with transplants would have been in the blue box, essentially. So they would have been in the group that NIAC said, all other things being equal, we would give them mRNA vaccine but don't delay was the key message. And when we looked at this, and we did look at this really quite hard in terms of the vaccination program, because of the mRNA vaccine being committed to people who are 70 years and older, and that was a government decision, and given the numbers of people we had to reach in that cohort, we worked out that there was no way we would be able to get the people in that group vaccinated within 3 weeks with mRNA vaccine, because we just didn't have the supply. And then in keeping with the NIAC decision, and everybody I've talked to, I suppose, in this area, I think is agreed, is that getting a good vaccine, getting a vaccine now is better than getting another vaccine in 2 months' time. And so it will be the same vaccine for people with transplant as others. And that's just very pragmatic, that's the vaccine we've got. It's a very good vaccine. In our opinion, and I think the opinion of almost everyone we've talked to, it's a lot safer to get that now than to wait for some other vaccine that might or might not be better. And again, the key message, I think, is that whatever evidence there is about differences in preventing infection, the evidence that all of these vaccines are really good at stopping you from ending up in ICU.
Yeah.
And thank you for that. And in terms of somebody, we've got a question from somebody living in Donegal, and that they attend Beaumont, and it's quite a distance away, and it's quite difficult to get to. They say, is there a choice? Is there a possibility of maybe getting vaccinated by your GP?
Well, certainly we will do all we can to accommodate people with regards to vaccination. At this moment in time, the program for the people with more severe form of CF is in the hospital setting, really. But again, I think as Martin will attest, we have to be flexible, and we can do it through our colleagues in the hospitals in Donegal as much as we can here in Beaumont. And we have, as you know, Philip, a hub and spoke approach to CF to a large extent. And a lot of our people from Donegal will come down to us on a regular basis, but we'd share care to an extent also with our colleagues. So we'd be happy to do that if necessary. Yeah.
Okay, well, thanks for that. Is there, in terms of the interaction between COVID-19 and new medications like the CFTR modulators,
Yeah.
Are there any concerns or anything that's emerged from that, Gerry? Probably for you.
Yeah, there's no data for any concern there at the moment, Philip. And again, it's one of these bizarre things that in the CF world we are seeing these fantastic modulators coming along at a time of challenge from COVID infection. But to put it in context, the modulators work and we want to use them, and the vaccines work and we want to use them. So we shouldn't delay taking either of those on the off chance that there might be an interaction, because there can be funny interactions with all drugs, but the data we have would suggest there's no direct interaction between the vaccine and the modulators that we're presently using. And I would advise people to stick with them.
A question about very high risk and high risk. Is it possible to distinguish between people who are very high risk and high risk with CF?
Well, we can, and we've been doing it for some years now in Beaumont, and we've done it based on a thing called an ABLE score that you were aware of. An ABLE score actually uses a lot of the parameters that are used in the HSE definitions. So if your lung function's low, and we'd say less than 50%, that is a high risk. If your BMI, in this case, less than 16, we'd say less than 20 actually is a risk. And then there's other things as well, recurrent infections, a risk. So we know from our own experience in Beaumont with our own scoring system that if you have a low pulmonary function, a low BMI, and frequent infections, you are high risk, very high risk. And you should be vaccinated.
Thank you for that. Somebody's asking about vaccinations with the flu vaccine. Is it possible to give the COVID-19 vaccinations along with the normal flu vaccination?
I defer to Martin on that.
Yeah, well, we don't give them, we wouldn't recommend getting them at the same time, but people would have had the flu vaccine quite a while ago now. Again, I'd have to check the NIO guidance, but from memory, and I would emphasize this is from memory, it's something like you shouldn't get another vaccine. You wouldn't get it normally, I think, within 2 weeks or something like that of previous vaccines. So there's a fairly short time period. From memory, I think it's about 2 weeks that you wouldn't get another vaccine. So for the flu vaccine that people have had last year, that's not that would have been late last year. That's not a concern. But as I said, there is a recommendation, and it's not that we expect anything terrible would happen to you if you had the two vaccines together. In fact, probably it would be fine. But I think part of the concern would be in a sense that maybe if I could put it this way, your immune system might be better off to concentrate on doing one of them at a time rather than being divided. But I think, to be honest with you, if somebody inadvertently got the two vaccines a week apart, I don't think anything bad would happen. I don't know, Gerry, what your view on that, but I think it's highly unlikely anything bad would happen, to be honest with you.
Yeah, I agree, Martin, but I think it's one of the advantages we have in the CF community is that our people are vaccine savvy, because we're always telling them to get flu vaccination and that sort of thing. So they're very aware of vaccines and how good they are. So this is a positive, I think. But you're right, I wouldn't take them together. Yeah.
Well, thank you. And I think this is one for you, Martin, is when will children and young people with CF get vaccinated? Your best estimates, because we know there's
two issues on that, I suppose. One is that we don't have a licensed medicine for children. Well, Pfizer is licensed down to 16. So, if you use the UN definition of child who finishes at 18. So, if you take that definition, Pfizer is licensed for 16-year-olds. Trying to manage that is difficult at the moment in terms of vaccine supplies, but we are sort of looking as to whether we can, because the vaccine is committed to people who are 70 years and older, but we are looking at whether it's possible to do something. There's a small group of people whose leaving cert is coming up, and we're sort of trying to see if there's something we can do about that, because it's just such a big life event. And it's really important for people. So within the HSE, we are looking at whether we can do something to try to support that. But generally speaking, I think you're going to be looking at quite some time before we're vaccinating children. And if you're looking at people under 16, as I say, the problem at the moment is that A, there's no vaccine, there's very limited vaccine for anyone, but B, there's no licensed vaccine for under 16. But I do understand that there are studies underway. So I would think it's quite likely that there will be something licensed later this year for children. And I suppose the other point, as most people are aware of, is that while children do get infected, severe disease in children is extremely rare. But I suppose so that there's less urgency in the sense of the vaccine that we have. There's generally less urgency about getting to children. So I suppose the answer is I don't know. I think it'll be late, probably well into the year before we get to most people, certainly under 16. But I think we are seeing it. We're looking into seeing what we might be able to do around a small number of young people who've got the Leaving Cert coming up and who might be at high risk or very high, well, particularly the ones who are at very high risk.
Well, thank you for that. And can pregnant women or women who are breastfeeding get vaccinated?
Yes, breastfeeding is we don't have a concern about breastfeeding. There is a window in pregnancy during which we don't recommend vaccine is not recommended, so in early pregnancy, deferred. Again, this is there's a window of weeks. I always check things rather than my memory, but it's something like up to about 14 weeks. We say you shouldn't have the vaccine. Again, I would say if somebody had the vaccine inadvertently, I don't believe there's no evidence that it's harmful to have the vaccine in that 14 weeks, to be honest with you. Again, it's this abundance of caution. We know pregnancy is a particular important time. The studies didn't include pregnant women, although actually some people who got the vaccine got pregnant during the trial. So there's no reason that I know of to expect that getting the vaccine in pregnancy would do any harm to either the woman or to the baby. But we don't have the evidence on it, and so at the moment, then it's deferred until later pregnancy. If that's, I guess, the answer, if that's okay.
And then just the question about the registry, I think it's probably for you, Gerry. Will the CF Registry of Ireland capture some of the data in relation to COVID-19, like the numbers of people who've got it and the severity and stuff?
Yeah, I think we will capture that data, and I think it's an area of extreme interest and importance for us, Philip, because we may be pleasantly surprised that our people are not being more susceptible to the virus than others and do not get as severe an effect as we would have thought, But certainly we have to get the data first. So we need to collect that data as part of the registry and follow people up as well. Because I think there's a question there about the long COVID syndrome. I noticed in one of the chats there, or the question, and we're seeing some long COVID syndrome in the general population here in Beaumont, but not in our CF population.
Excellent. And listen, thank you so much. We're just moving on to the last 15 minutes of the webinar. And my colleague, Dr. Sarah Tecklenborg, is going to be doing this. And I'm delighted to welcome Sarah, who's added a real capacity to Cystic Fibrosis Ireland around both policy and research. And I'm also delighted to welcome Patricia Duffy Barber, who's a former chairperson and now our vice chairperson, and Keith McCabe, who's our present chairperson. And people will know that Tricia is a person with cystic fibrosis and that Keith is a parent. So you're very welcome. And Sarah is going to moderate this part of the discussion.
Thanks, Philip, and thanks everyone for joining us. I see lots of questions there coming in, particularly from parents of children with CF, which I suppose both Patricia and Keith, you might be able to come in on this on. And they're concerned about obviously when they might get it. I know, Martin, you've given us an update there. We had updates from Pfizer and Moderna during the week that they expect the results from their trials at age 12 and over to be coming in the next couple of weeks. And then they've also begun the trials in children younger than age 12. But lots of parents out there talking about, will they be able to get, so for the parents where their children is not able to get the vaccine in the distant future, will the parents or the family members and carers be able to get it in order to provide protection to those? And I suppose that also leads into, does the vaccine itself prevent transmission of the virus? So Martin, I don't know if you'd like to.
Yeah, I'll certainly try. So in relation to the parents, first of all, I mean, the unwelcome answer is that there isn't any prioritization for parents of people with CF or other conditions in the policy, and the HSE is required to follow the policy. I would just say as well that since the Chief Clinical Officer asked me to take on the role as a clinical advisor to the vaccination program, I've had a huge amount of correspondence from people about getting the vaccine early, and I haven't had correspondence from a single person that I wouldn't like to give the vaccine early to. And I've had hundreds, not one, every one of them I'd like to give the vaccine early to. The hard end of this, and it is hard, is that the only way one person gets vaccinated early is that somebody else moves down. There just isn't enough vaccine. And that's, I know that's unwelcome and people don't want to hear it, and I've had to write it to a lot of people, some of whom were not very happy to hear it, but that, you know, there just isn't enough to go around. So and then in relation to preventing transmission, the evidence is getting better around that, I think, is the answer. I think in the early stages, I think we were saying it prevents disease and death, but I've seen studies from Israel in particular showing that people who've been vaccinated seem to shed less virus. And there's also clinical studies growing now showing reduced evidence of transmission. So I think there is growing confidence that in addition to preventing disease, that it also will reduce transmission. But again, you know, it's not going to be perfect. It's going to work well for most people. And just reflecting back on the discussion earlier about people who transplant, I suppose we're less sure, less confident that the vaccine is going to give the same level of protection to people who are profoundly immune compromised that we are about other people.
And just thank you. And just on that, then I suppose for the post-transplant groups, you know, we have again also had lots of questions in about that. What additional precautions will they need to take after they're vaccinated? I think we're all hoping that we get vaccinated and might allow some return to normal life. But what do people with CF, and in particular the post-transplant groups, if the vaccines are slightly less effective in those groups, need to continue to do?
So again, we're working through the advice on that and sort of taking the cautious approach in it. So one of the messages, I suppose, that we've been giving in many contexts to vaccinated people so far is keep your guard up. First of all, no vaccine. The vaccine isn't going to do anybody any good the day they get it. I know I'm harping on about that, but and you've got probably a very experienced audience, but people do get caught out. So and psychologically, I think people tend to, even when they intellectually know it, I think psychologically there's a tendency to drop the guard when you've got the vaccine. So that's the first part. And then we're working through the sort of advice about how people can get back to normal after the vaccine. The first part of that, I suppose you will have seen, was that there was an easing of the restrictions on visiting in nursing homes following vaccination. I think we'll be seeing some more progress in relation to various people who are over 70 being told that they no longer need to follow specific restrictions. And I think we'd probably be looking at when we feel confident that we can say that to people who have medical conditions. The hardest group to answer that question for is going to be the immune compromised. You know, so I think we will be able to give a better answer earlier. And one of the difficulties with immune compromise is that it's not a homogeneous group. It's just such a diverse group. I mean, there are some people who have a mild degree of immune compromise. Some people are profoundly immune compromised, and people's degree of immune compromise changes over time. So even though we talk about the immune compromised as a group, it's actually a very, very diverse group. Very hard to give a clear answer. So we're working on it, but I think that's probably the answer that's going to come latest. To be honest with you, is the answer. I'd love to be able to say, you know, you've had your vaccine, everything goes back to normal. I think we're going to be cautious, and particularly about the immune compromised group. And I think we're going to wait and sort of see what experience builds around it.
Thank you. Patricia and Keith, I suppose, how's the progress that's been happening this week? How's that making you feel, and what difference is that making to you?
Ladies first, Patricia.
Thanks. It's been great to see. I think it sort of reached a tipping point last week with people saying, have you heard anything? Have you heard anything? And then slowly people were getting phone calls, and just the excitement of going in. And, you know, I think there's a little bit of euphoria, and, you know, once they get the vaccine, I think they realize that we still have to wear masks, we still have to stay home, we still have to follow the precautions as best we can. But it does represent a huge weight lifted off people. Personally, myself, I work with the HSE as a speech and language therapist. So I was able to avail of my vaccine in January. I got the Pfizer vaccine at that point. And just the feeling of that was fantastic. As you mentioned, the side effects, personally for me, that was a 4-week apart dose. The first dose, I just had the immediate kind of pain in the arm. And then the second dose, the vaccinator very kindly said, you might feel hungover the next sort of 24 hours, 48 hours. And that's exactly what it was. Just really feeling knocked sideways. But in a way, I didn't panic because I knew, look, this is just a temporary thing, and just took lots of fluids, took it easy, and literally by the 48 hours, I was back to myself again, almost as if it had never happened. So it was a very short-term pain and feeling unwell for the 2 days. But it's just good even to share that story, I think, because then other people know what to expect, that people know their own bodies, they know themselves, but just that you will feel out of sorts, but you do come back to normal. And of course, if you don't, or if you feel something different starting, or you're just not happy, not to ignore it and put it down to the vaccine, to follow up with your team if you feel a little bit unwell or you have an unexpected complication. But yeah, it's from people with CF, I think it's just been, it couldn't come soon enough. And I think people have been delighted with it.
Keith?
Yeah, well, obviously I can only just double in on what Patricia has said. I think the momentum that I've seen just in hearing from colleagues, from people that are obviously in the community, it's definitely been a positive week. Seeing the badges and the photographs going up online, it definitely feels that it's moving in the right direction. I think as a parent, obviously my son isn't eligible, as you alluded to, Martin, in terms of medicine not being available. He's only 7 years of age, so we're a way away yet, I suppose, from looking into how that can actually be more mainstream. But as you said, it's showing less of an impact on those that are of that age group, Martin, in terms of disease and how that actually could impact people, as per Gerry also said. I think the only piece that, and it's you're saying no to lots and lots of different people, Martin, in terms of their prioritization. It's probably parents are categorized themselves as frontline workers that are carers for people with CF. So that's where that piece at times probably does create a conflicting interpretation of what is actually a carer. A carer is a parent, and a parent is a frontline worker in a lot of capacities, and when they are caring for someone who perhaps is of an older age profile. So from a parent carer perspective, that sort of cohort, of course, should definitely be viewed, in my opinion, at least, in terms of being a frontline healthcare worker. The work that we do with our children that do live with cystic fibrosis is that of a carer and of a parent. But to just come back on that other point, in terms of the momentum in the community and for Cystic Fibrosis Ireland in general, it is definitely a good week. We're seeing people getting their vaccines. That's definitely uplifting. And we need to make sure that as a society and as an association, we maintain that sense of positivity in relation to it. My only final other comment, Sarah, in relation to it is, thankfully my son hasn't actually had any illness of any description over the last 12 months. And perhaps Gerry alluded to that earlier on, it's less infections, it's less coughs and colds that are in mainstream circulation. And that definitely has hopefully given a longer term impact on his lung health as he progresses into adulthood, which has been a definite positive, albeit having him, a 7-year-old, stuck at home with 2 other children has had its own challenges, as I'm sure you can all relate to. But no, overall, Sarah, definitely good. And as an association, we need to make sure we're still doing what we can to advocate for the wellness of everybody with CF. And the parents definitely play such an unseen but important role in that. And their vaccination prioritization, categorized as carer, to me should definitely be continually reviewed to ensure that they get that cover and protection that they deserve as a frontline worker.
Thanks, Keith. Yeah, I mean, that's definitely something that's come up the whole year round, and the frustrations over not knowing when they'll be protected as well, and not have, as you said, not having the hard work recognised. I suppose that's been ongoing. Professor McElvaney, it must be lovely for you to finally be able to give good news out to people when you're giving them the call for the vaccine, etc. Do you have any other words for us?
I remember when I got it myself, and I was delighted to get it, and I was even more delighted when I got the second vaccine. So I think it's a great thing. I think it's been handled well. I think it's going to work. No doubt it's going to work. And I think hopefully we'll be all back to a more normal environment as soon as possible.
Exactly. Thanks. Philip, I might hand back to you. There's no other questions that I can see coming into us.
No, thank you. Thank you so much.
Philip, could I make it?
Yeah, Martin, please. Yeah.
I mean, I just, in terms of what Keith has said, I certainly would be sorry that anyone would see this as being a failure to recognise the work of parents. It really isn't. The National Immunisation Advisory Committee, which I'm not on, but which is a really tough job to do, tries to make judgments that I think none of us would like to have to make. And then we try to implement decisions that none of us are comfortable making, to be honest with you. So I don't know, as I said, I haven't seen a single letter that didn't make me think, God, I wish there was a way to vaccinate that person. there just isn't enough to go around, and it's certainly not intended in any way as a failure of recognition of the work that you do.
And that's absolutely not the message, and I guess it's reassuring, and I don't envy your position, Barton, in terms of trying to categorize who is perceived as sicker or more deserving. I think that's always going to be a difficult journey for people to go through, but I think from a parent carer's point of view, that's always definitely in the more front of the mind of just making sure we're doing everything we can to protect our children. And you know, at times you are, as I said, that frontline healthcare worker, and that's our day-to-day role. You know, much and all this, take off your shoes, wash your hands properly. That's been our mantra since day zero anyway. So definitely COVID has had a lot of benefits in helping us to reinforce cough etiquette and hand hygiene, which is fantastic. But I think now, when yes, it's the vaccination list, and it's the who can get to the top fastest. Of course, we have to try and advocate for parents, particularly those perhaps that have children that are, as Gerry alluded to, perhaps sicker, perhaps or have a higher severity in terms of their cystic fibrosis. But listen, it's a continually reviewed process, I'm sure, and it's something that can hopefully continue to be looked at as we go forward into the coming summer months.
Thank you so much, Martin and Keith. And I'm just minded by a campaign by a person with CF a number of years ago. She was trying to improve coughing and sneezing etiquette on airplanes. And we approached Aer Lingus and Ryanair, and they just didn't want to have anything to do with it, you know. And maybe just one positive legacy that might come from this, as Keith was talking about there, is that maybe people will be more conscious the next time they cough and they sneeze, particularly in an environment where, you know, the germs can be transmitted very, very easily. But I just want to thank everybody, and particularly our keynote speakers, Gerry and Martin, and to my colleague, Sarah and Nuala and Sam and Liz and everybody who contributed to this webinar this evening. Thank you so much to our chairperson, Keith McCabe, and vice chairperson, Patricia Duffy Barber. And we will get back to your questions. There was some questions we didn't get through, but just because of time factors, but we will get back to you, and we will post online. Just to remind you, our conference is on 7th and 8th of June, if I'm right, the evening. The 6th and 7th of June, so thanks for that slides. So 5:30 to 8 o'clock, and there's a gap in between. There's also a concert on Cystic Fibrosis Day, which is Friday the 9th of April, and with people like Brian Kennedy, and you know, it's just fantastic lineup. So we hope that you can celebrate with us on that. We usually have you know, a lovely dinner dance at our annual conference, and we can't have that this year, but maybe this is the next best thing. So I just want to wish you all the very best. I know it's been a very anxious time. I know that anxiety continues, but there is light at the end of the tunnel. And just to let you know again, the Cystic Fibrosis Ireland is here for you in this difficult time. So thank you so much, and have a very good evening. Thank you.